Thank you for giving me this opportunity to speak today. I'm hoping to shed some light on the mysteries of complex multiple implant cases. In our everyday practices, we often encounter many patients such as these who have already lost alveolar bone. Obviously, their quality of life is significantly affected by this condition. Today, I'll talk about how to treat these cases to the satisfaction of the patients. In single implant cases, the papilla between the implant and the natural tooth will be supported by natural periodontal attachment. But in multiple implant cases, we must mimic a natural healthy appearance by managing surrounding tissue with abutments and superstructures. The main complication in the aesthetic implant therapy are the recession of labial tissue and the lack of papillae. Both are caused by bone remodeling and the biologic limitations of the relationship between implants and soft tissue. There are a number of solutions available to us. Today's main topics are 5 and 6, the 3-dimensionally and 4th dimensions of tissue augmentation. To begin with, I'll run through a brief explanation of the first 4 solutions. First, the use of pontics. When implants are placed and the abutments are connected, there will always be a disruption in the continuity of the bone and soft tissue. This inevitably leads to the loss of bone and soft tissue. We can keep the continuity at the pontic site. Dr. Sarma et al. Charted the expected soft tissue height in varying restorative environments from class 1 to class 6. The advantages of using pontics can be clearly seen here. If we must place implants next to each other, we should attempt to position them as distant as possible. Even at the minimum distance of 3 millimeters, we will often only be able to preserve a very small papillae. Whereas placing implants at distance of 4 millimeters has a much greater chance to preserve optimal papilla. Platform switching allows us the ability to preserve the bone crest between implants by distancing the bone from the implant abutment connection and the inflammatory cell infiltration zone. Platform switching was used on the implants, and after more than 3 years, the bone crest has still not changed, even though the inter-implant distance is less than 3 millimeters. Reduction of abutment disconnection is possibly a useful solution. Three-dimensional consideration for hard and soft tissue is imperative for successful long-term aesthetic restoration. Any failure in the hard tissue surrounding the implant, in turn, affects the overlying soft tissue, and that determines the final appearance. Appropriate 3D bone counter is necessary to place implants in their ideal position, to provide support for aesthetic soft tissue frame and to act as a countermeasure to bone remodeling. Thinking about the goal of bone augmentation, it depends on the purpose such as function or aesthetics. In every individual case, the goal of augmentation, either function or aesthetic, depends on the site-specific requirements. For example, this is a 63-year-old woman. She wanted a fixed prosthesis, but as you can see, there isn't enough bone to support implants properly. In this case, sinus and vertical ridge augmentation was performed. You can see that almost all of the lower right first and second molar implants are positioned in regenerated bone. This is after treatment. Understandably, this patient's quality of life improved dramatically upon completion of this treatment. These are step-by-step through the vertical guided bone regeneration process. This X-ray also details the regeneration process. This is before treatment, and this is before abutment connection. Free gingival graft was performed to get keratinized tissue around implants. Thanks to alveolar bone augmentation, we are able to position implants in sites which were previously thought to be impossible. In the posterior region, we think the goal for bone augmentation is simply acquiring enough bone for implant support and to get cleansability. Of course, adequate keratinized tissue around the implant is also necessary. In the aesthetic zone of the anterior region, we must consider many more variables than the non-aesthetic posterior region. Thinking about soft tissue management in the aesthetic zones, Dr. Kang et al. Found that thick type soft tissue will always result in a higher tissue height than the thin type, so it is also easy to presume that tissue augmentation will provide a greater defense against recession and quite possibly preserve more tissue height. Because bone thickness less than 1.5 millimeters will result in recession and papilla loss, Dr. Grunder reported that the bone thickness should be at least 2 millimeters at the buccal side. Furthermore, he supposed that in neighboring implant site, sufficient bone thickness on the buccal side could support the buccal portion of the inter-implant papilla. Ultimately, both soft tissue and bone tissue should be thick enough to maintain tissue continuity and provide an aesthetic tissue frame. As we know, upper lip position is a basic standard for every prosthetic procedure. We can estimate where the bone height should be from the resting upper lip position. There are several other standards for vertical bone height. Dr. Salama et al.'s IHB classification gives us guidelines to create optimal papillae. I think that we should aim to establish a Class 1 IHB. When we hope to harmonize implant superstructures with existing healthy teeth, the line connecting the interproximal bone peaks is particularly useful guide. Of course, IHB also a necessary standard on which we base the shape of the crown. When we place implants, we have another standard to evaluate bone height. Taking into consideration the natural tooth biologic width of 3 millimeters, the necessary 2 to 3 millimeters distance between free gingival margin and the platform, and that the osseous scallop is roughly 3 millimeters, the interproximal bone peak ideally should be 2 to 3 millimeters higher than the platform. This is before augmentation. This is after augmentation and implant placement. This is before treatment. This is a provisional restoration. This is a periapical X-ray. As you can see, the interproximal bone peak is around 3 millimeters above the platform. We know that simple extraction procedure leads to the tissue loss. Immediate implant placement with tissue preservation procedures are effective against this tissue loss. So, timing of procedure plays an ever-increasing role in all complex cases. In most complex cases, alveolar bone had already been lost. So, we must reconstruct the alveolar bone structure to create a natural aesthetic outcome. This patient had advanced periodontal disease and severe bone loss. In the next slides, I will walk us through some of the steps involved in a complex multiple implant case, placing an emphasis on the timing of augmentation procedures. These photos show significant horizontal vertical bone defects in the anterior region. Recently, tooth number 8 and number 11 were spontaneously lost. When we treat this kind of case, we have to consult the patient about their final expectations. Diagnostic workup and provisional restoration are very useful to evaluate remaining tissue and the patient's hoped for results. In this case, I realized that the desired height of augmentation was the level connecting the right canine to the left first premolar. The CT scan and simulation software show a challenging situation. Taking about the 4D multiple implant solutions, I plan to place these implants following the guideline. Okay. These are cross-sectional images. The yellow boxes are planned implant sites. Considering the 3D augmentation requirements, all 3 sites need bone augmentation to some degree. This was before augmentation. Guided bone regeneration was performed to establish a bone foundation. This is after the first augmentation. The tooth number 11 implant was covered with regenerated bone. A 4 millimeter high temporary hearing abutment was connected to the implant to get vertical support for the next augmentation. The tooth number 7 was immediately replaced by an implant. So the buccal wall was well preserved. From this, we realized the importance of timing of procedures. Then, it's time for vertical augmentation. This imaginary line is a level which we evaluated in the diagnostic phase. The goal of hard tissue regeneration is to obtain enough bone height in order to support the papillae around implants. This is not the same as the height required for simply placing the implants. Second GBR was performed with cross-linked collagen membrane. Now, we have enough bone height to support papillae at each interproximal area. This is the occlusal view during bone augmentation. Typically, we must ensure that there is at least 2 mm bone thickness on the labial side of the implant. If not, compensation with soft tissue will be necessary. This is after guided bone regeneration procedures. Almost all of the number 9 implant was placed in the regenerated bone. But there was insufficient thickness on the buccal side of the implant, so high quality thick soft tissue would be required. In soft tissue augmentation, we need 2 things: sufficient counter and keratinoid tissue. After bone augmentation, we had adequate tissue counter, but we were still needing approximately 4 mm of keratinoid tissue. So, 2 pieces of subepithelial connective tissue with 5 mm gingival band were harvested. After number 9 implant placement, subepithelial connective tissue was stabilized like this. The yellow line shows the shape of the subepithelial connective tissue graft, and the red line shows the apically positioned mucogingival junction. Looking at this photo carefully, you can see that we didn't lose tissue height because the first incision line is well below the highest tissue level. The grafted keratinoid tissue band will blend with the original keratinoid tissue because the grafted connective tissue is covered by the original keratinoid tissue. And we will have sufficient tissue counter and keratinoid tissue. This is before augmentation. This is after bone augmentation. And this is after soft tissue augmentation. Enough keratinoid tissue and a good counter was acquired. These are occlusal views. From this angle, we can see that both keratinoid tissue and counter were sufficiently achieved. Then a punch-out procedure and abutment connection was performed. These are X-rays of before and after treatment. Alveolar bone counter was much improved. This is before and this is after treatment. you can see the natural-looking teeth and the soft tissue frame. These are lateral views of before treatment, and these are after treatment. This is before treatment, and this is final result. This periapical X-ray shows enough bone height. When he smiles, we realize that the regenerated tissue harmonizes with his lips, and it is difficult to imagine how he looked before treatment. In this case, first horizontal augmentation was performed to create a foundation. Then an implant was immediately replaced, which was critical to preserve buccal bone. At the same time, vertical augmentation was performed to provide aesthetic tissue support. Finally, an implant was placed in the most critical aesthetic area, and at the same time, the soft tissue augmentation procedure was performed. In case like this, with a severely damaged ridge, well thought out timing of procedure is the key of success, key to success. In complex cases, the selection of abutment teeth is essentially equal to the timing of procedures. We have established some rules to make this selection easier. I will now discuss this selection process. These are periapical X-rays. If I place an implant at the number 9 position, I could alternate pontic and implants across the whole defect area. Yet, considering the size of the defect, I felt it was more important to place implants in the more stable original bone than to avoid placing neighboring implants. So, I planned the case like this. This yellow arrow shows class 1 IHB for a planned inter-implant papilla. I had to preserve this bone peak as much as possible. We have to maintain tooth function and aesthetic during the treatment period, which can last for years. Therefore, the provisional restoration and also the selection of temporary abutment teeth become very important. Temporary abutments are not only for supporting restoration, but also performing these for other crucial functions. The canine number 6 was used to support the provisional restoration and to help preserve the peak between number 6 and number 5. I plan to perform immediate placement in the number 6 position after the number 3, number 5, number 8, and the number 11 implants were functioning. Resorbable membrane was used for horizontal augmentation. At the time of this case, we felt that using titanium reinforced non-resorbable membrane for vertical and horizontal augmentation was our best choice. Recently, we are thinking that resorbable membrane and titanium frame might have been a better option. This is before and after augmentation. After augmentation, we have enough bone height to support papillae. We have established an optimal symmetrical ridge. and enough tissue height to create papillae. Staged consecutive implant placement technique at number 5 and number 6 was used to preserve the bone peak between two neighboring implants. This is the final result. We managed to preserve inter-implant bone crest and create a good papilla between two neighboring implants. In the anterior region, the use of pontics helped create good tissue contour. These are before and after the ridge was vertically augmented. Looking at these slides, it is quite difficult to guess which are the real teeth and which are the implants. This is before and after treatment. Considering the patient's lip line, it is immediately apparent why successful tissue augmentation is critical to patient satisfaction. To manage a complex cases successfully, careful selection of abutment teeth must go hand in hand with the timing of individual procedures. In conclusion, to manage multiple implant cases, specific treatment goals should be set. Consider the biologic limitation and take countermeasures. Preserve and three-dimensionally regenerate tissue as much as possible. Always consider the timing of procedures, which we have named the 4D concept. In complex cases, it is considered challenging to get natural-looking aesthetics. When we achieve this, we could significantly change the quality of our patients' lives. Thank you for your attention.